Good morning, everybody, and welcome back. This morning, we have a lot of non-pulmonary critical care talks that are always really engaging. And this is one of my favorite ones because I think I use this probably every day that I'm in the ICU. So the first talk this morning is by one of our neurologists, Dr. Zafar, on common neurologic issues in the ICU. Dr. Zafar.
Thank you. Good morning, everyone, and thanks for having me back. I'm excited to be here, and appreciate everyone joining in. So I am a neurointensivist at the Mass General Brigham, and I will, of course, be reviewing common neurological issues encountered in the neuro ICU or in the general ICU. These are my disclosures. None are related to the content of the talk today. So what we'll be covering today is just approach to measuring and managing intracranial pressure, and followed by a review of disorders of consciousness, disorders of movement or abnormal movements that again are frequently encountered in the critical care setting. And then we'll conclude with just a few case studies or case examples. So starting with intracranial pressure. The concepts of intracranial pressure can best be understood by the Monro-Kelly doctrine. And this doctrine states that the volume of the intracranial contents must remain constant. So what are the intracranial contents? These include the brain, CSF, as well as blood. And what the doctrine states is that if there is an increase in one of the components, so say, for instance, that there is a brain mass or a bleed that results in an increase in the volume of brain content, there is a compensatory decrease in the other. So there's redistribution of CSF out of the brain's CSF spaces down into the spine, and there can be redistribution of blood through the venous sinuses. And when this sort of process of homeostasis is maintained, the normal intracranial pressure typically ranges between 5 to 15. And we define pathologically increased intracranial pressure as sustained pressures greater than 20 millimeters of mercury, and that's sustained for longer than five minutes, typically is what we use as our cutoff. In addition to the Monro-Kelly doctrine, another important concept is that of intracranial compliance. This is very similar to pulmonary or lung compliance, where for a certain range of intracranial volumes through the compensatory mechanisms that we just described, as the volume increases, the intracranial pressure is maintained. However, there comes a tipping point beyond which the normal compensatory mechanisms can no longer keep up, and slight increases in brain volume, in intracranial volume, result in significant increases in intracranial pressure. And this is when we start to see tissue shifts, defined as herniation syndromes. And herniation syndromes can range from subfalcine herniation, which is the herniation of the frontal gyrus under the falx cerebri, uncal herniation, which I think is the one most people are familiar with, which is herniation of the uncus over the tentorium that results in pupillary asymmetry and posturing. There can be downward herniation of the cerebellar tonsils, and then there can also be central transtentorial herniation where the entire brain is sort of sagging. And then if there is a brain defect or, skull defect, there can be transcalvarial herniation through the skull defect. And so when there's loss of these, when the Monro-Kelly doctrine can no longer be maintained and the volume exceeds the compensatory mechanisms, is when we start to see tissue compression as well as herniation syndromes. Another important concept is that of cerebral autoregulation. And here I have two key formulas that we look at. One is the cerebral perfusion pressure, which is essentially the difference between the mean arterial pressure and the intracranial pressure. And then the second is cerebral blood flow, which is cerebral perfusion pressure over cerebrovascular resistance. And what you can see here is that in the normal brain, across a range of cerebral perfusion pressures, cerebral blood flow is actually maintained, and this is through changes in cerebrovascular resistance, and this maintains a normal blood flow and homeostasis in the brain. In chronic hypertension, this curve is shifted over to the right. And so you can see again, across a higher range of CPPs, cerebral blood flow is maintained. But in patients with acute brain injury, and this could be stroke, this could be trauma, this could be more diffuse brain injury, such as an anoxic brain injury, this relationship between cerebral perfusion and vascular resistance is also disrupted. And you can see that slight increases in CPP result in there's a linear increase in the cerebral blood flow as well, which again can result in higher intracranial pressure. And so again, these are sort of the key principles to keep in mind, that of the Monroe-Kelly doctrine, the intracranial compliance, and then the relationship of the cerebral perfusion pressure, vascular resistance, MAP, and intracranial pressure. So these are the sort of CNS or central determinants of intracranial pressure, but there are also systemic determinants of intracranial pressure. We already talked about the mean arterial pressure and how that may impact cerebral blood flow and intracranial pressure. Jugular venous pressure, as we talked about, the jugular veins are a key outflow tract. So if they're obstructed, if there's venous sinus thrombosis, for instance, that can result in raised intracranial pressure. Increases in thoracic pressure can impact intracranial pressure. Posture is key, so head down results in higher intracranial pressure. Head up, especially to 30 degrees or 45 degrees, alleviates intracranial pressure. And that is why when we are concerned for an ICP crisis, we will bring the patient's head up and ensure that their MAP, their blood pressure are all being maintained. Partial pressure of carbon dioxide is key. The cerebral vasculature is very sensitive to PCO2. And so that is a key determinant. And then temperature as well. Higher temperatures, hyperthermia, can result in higher intracranial pressure as well as cerebral edema. So when we think about managing, and we'll get to management in a few slides, these, in addition to sort of the treatments we institute for intracranial pressure, these are key components that we have to keep in mind as we're managing patients that have elevated intracranial pressure. So what results in high ICP? We already covered some of this, starting off with just increase in brain volume. And this can be brain masses, they can be tumors, hematomas, abscesses, hemorrhage from trauma, all can result in raised intracranial pressure. There can be cerebral swelling that can be secondary to ischemia or infection. And so this can be both focal or regional swelling around the area of injury, or it can be more global swelling, for instance, in infectious etiologies or in patients with anoxic brain injury. Outflow obstruction of the CSF, and that, for example, in cases of hydrocephalus or subarachnoid hemorrhage. And then, of course, jugular venous outflow obstruction, as in the case of venous sinus thrombosis. All of these can result in elevated intracranial pressure. And so if a patient does have high ICP, what are the key signs and symptoms? Some of the most common symptoms include headache, that is typically worsened by Valsalva maneuver, decreased visual acuity, double vision, nausea, and vomiting are amongst the most common symptoms that a patient may present with or have when they have elevated intracranial pressure. Signs, there's, of course, progressive decrease in arousal. There can be impaired eye movements. This is especially because higher ICP can push down on the posterior part of the brainstem that controls eye movement, and that can result in impaired upgaze. And then cranial nerve 6, which has the longest track, is most susceptible to elevations in intracranial pressure. So you can see cranial nerve 6 palsies in patients that have elevated intracranial pressure. Papilledema and loss of normal venous pulsations on fundoscopic exam, and then enlarged blind spots. And then the Cushing's triad, this is sort of the, this is a sign of impending herniation, or sort of, what we call the doom sign, is a combination of hypertension, bradycardia, and irregular breathing, or the Cushing's triad. And when we see a patient have this combination, we're concerned that there may be impending or ongoing herniation that requires more emergent treatment, as opposed to some of these other signs, which may be earlier, if they just have a headache or double vision, those may be earlier signs of raised intracranial pressure and may not yet be suggestive of an impending herniation. And so when do we consider monitoring patients? There are certain key diagnostic diagnoses that we do use intracranial monitoring for, the most common being the traumatic brain injury. And the Brain Trauma Foundation, in fact, has guidelines that recommend or provide indications for intracranial pressure monitoring. And so per the Brain Trauma Foundation, for patients with traumatic brain injury, if they're comatose and have imaging abnormalities that include cerebral contusions, ICP monitoring is indicated. Or if they are comatose and they have no imaging abnormalities, but they have at least two of the following. They're older, they have posturing, or they're hemodynamically unstable, is when we consider ICP monitoring. And then, of course, if they need neuromuscular blockade for, an alternate or a different reason, and there's concerns that they may have high intracranial pressure, those are the patients that we do monitoring for. Another common indication is aneurysmal subarachnoid hemorrhage patients. And in these patients, we particularly consider intracranial pressure monitoring if there is associated hydrocephalus because of blood in the ventricles, where placement of these ventricular drains can not only allow monitoring of intracranial pressure, but also allow us to drain or evacuate intraventricular hemorrhage. So it's sort of a dual purpose in these patients. Cerebellar stroke, again, if there is a posterior fossa stroke, can result in hydrocephalus. And here the indication often more is to alleviate the hydrocephalus, where we may consider placement of external ventricular drains that allow us to both monitor pressure, but also drain CSF. Encephalitis or infectious etiologies, we will consider intracranial pressure monitoring if there's evidence of diffuse edema, if we've had CSF or lumbar punctures that show a persistently high intracranial pressure and we're concerned about high ICP, we may consider that this is one area where you can consider intracranial pressure monitoring. Similarly, for liver hepatic failure, where there's diffuse edema, this is where we start to see more practice variation, where some sites or centers routinely do monitor some of these patients, whereas at others, it's not a typical indication. Particularly for hepatic failure, if there is coagulopathy and other derangements that, increase the risks of placement of a monitor, we would avoid one. And so for diffuse hepatic failure or edema related to liver failure, for instance, is not an indication we routinely monitor intracranial pressure, but it has been used for this indication. And there is a literature to support it for this indication as well. So switching gears to modes of monitoring, and you can see here that there are numerous ways to monitor intracranial pressure there's parenchymal monitors, epidural monitors, intraventricular monitors, subarachnoid monitors. They can be placed in various different locations. The two most commonly used monitors are the intraparenchymal monitors that are placed into the parenchyma. Typical location is the right frontal lobe at a depth of about 2 centimeters. But we try our best to place these close to where the injury is, and if that's not possible, then it's the right frontal lobe. And the other most frequently used is the intraventricular monitors, also called external ventricular drains. And these have the added advantage of, in addition to monitoring ICP, as I discussed in our prior slide, you can also use this to drain cerebrospinal fluid. So it can also help in alleviation of high ICP through the drainage of CSF, and can also assist with drainage of blood in patients that have intraventricular hemorrhage. And so comparing these two most commonly used monitors, external ventricular drains and intraparenchymal monitors, EVDs are often considered the gold standard because they, provide a global measurement, but they also allow for a drainage. However, when it comes to accuracy, they're both fairly accurate, and often unless there's a clear indication or there's presence of hydrocephalus and we need to drain CSF or we need to drain intraventricular hemorrhage, particularly for traumatic brain injury patients, we often start with just regular intraparenchymal monitors is what we use. The cons for both are with EVDs, there is a risk for tract hemorrhage or meningitis or ventriculitis. So that's something that we sort of watch for. And then with the intraparenchymal monitors, we don't have the option for CSF drainage in these patients. And so if there is clear hydrocephalus or intraventricular hemorrhage, you may consider choosing the external ventricular drain over an intraparenchymal monitor. Another disadvantage of intraparenchymal monitors is that they have a drift, so they lose their calibration after about 5 to 7 days, and they can't be recalibrated. So if you need monitoring beyond that time frame, you either have to reinsert a monitor or use an external ventricular drain that doesn't have that disadvantage of losing its calibration. So again, it really depends on what the indication for monitoring is. For many trauma patients, an intraparenchymal monitor will suffice. But if there is clear evidence of hydrocephalus, intraventricular hemorrhage, or there's a need for CSF drainage, that's when external ventricular drains provide a distinct advantage. So once we do have concerns of elevated ICP or intracranial pressure, how do we treat these patients? And the first is, of course, identify goals. If there is an ICP monitor, we want to lower the ICP to less than 20 and preserve their cerebral perfusion pressure, which is typically, we like to keep that in the range of about 60 to 70. Higher cerebral perfusion pressures, there's some data to show that if it goes beyond or higher than 70, that in itself can also be associated with adverse outcomes. And then, of course, very low cerebral perfusion pressures, less than 50, are associated with adverse outcomes. So typically 60 to 70, or sometimes 55 to 70 is considered the goal or target for CPP. And then prevent tissue shifts and herniations is the other goal. And so just going back to some of the systemic determinants. So one, the first step is prophylaxis, and this is prevention of high ICP, which just involves maintaining normal homeostasis. So euvolemia, eunatremia, euglycemia, euthermia are all key in sort of preventing elevated ICP. If the patients have seizures, controlling seizures is another key mechanism. Then there's bridging measures. We talked about how the cerebral vasculature is sensitive to PCO2, and that rises can result in vasodilation and higher ICP. And so we do consider hyperventilation if there is an ICP crisis, but this is only used as a bridging measure. So it's only used as a temporizing measure till we can get hyperosmolar as we're rushing a patient to the operating room is when we use this. And so it's typically not done for longer than 15, 20 minutes or so, a half an hour at the most. Sustained hyperventilation has actually been associated with worse or adverse outcomes as well. So again, hyperventilation is typically just used as a bridging measure to more definitive treatment. Then the medication management, one of the main sort of medication managements we use are hyperosmolar agents. This includes mannitol, as well as hypertonic saline. Hypertonic saline includes 3% boluses or 23.4% boluses. There's no large trials or data to suggest one is better than the other. They all work by extraction of water from cells, and that's how they decrease cytotoxic edema. And so what we typically do is dose them based on comorbidities and ease of administration. So mannitol has the advantage, it can be given peripherally and it can be given very quickly. In patients that have renal dysfunction or renal impairment, there's a limit to how much mannitol we can give. And so, with renal impairment, that may be a consideration. Hypertonic saline, especially 23.4%, requires central access, although you can give a first-time bolus peripherally, but that can result in vascular necrosis. And then patients with heart failure, hypertonic saline can result in pulmonary edema and worsening edema. And so we typically use these comorbidities. Mannitol will cause diuresis in patients with traumatic brain injury or subarachnoid hemorrhage. Hypovolemia is particularly associated with worse outcomes. And so often, especially in TBI, there's some data to show that hypertonic saline may be more effective at lowering ICP. So often in patients with traumatic brain injury and subarachnoid hemorrhage, where particularly hypovolemia is worse for these patients, we can start with hypertonic saline as the first line. But in general, either is fine. And so whatever you can get in fastest is sort of the goal when you first have an ICP crisis, and then you can tailor subsequently once access is maintained based on comorbidities and etiology. And so as soon as we have a patient with ICP crisis, we try and administer whatever we can get in fastest. There is some question or debate over should we be using continuous hypertonic saline infusions versus bolus treatments. In general, the preference is bolus treatments because the boluses allow for the gradient that we leverage for treating or extracting water from cells during cytotoxic edema. And so ideally, the goal is to use bolus treatments, and they're administered every 3 to 6 hours or as needed for ICP. We can consider using maintenance infusion, especially for patients that come in very hyponatremic, where we're trying to bring their sodium up. Or once we hit a point where the patients have been sustained hypernatremic and we want them to slowly come down, is when we can consider a continuous infusion to prevent sodiums from dropping too quickly. But in general, we use bolus treatments of these two agents. Other measures, we talked about the external ventricular drain that allows drainage of CSF. Using anesthetics or sedatives, so barbiturates have sort of become more of a, not a first line measure just because of the known ICU related complications. And so if we are thinking of sedation, we typically will start with either propofol or midazolam for sedation, and things like pentobarbital are sort of a last resort just because of the known adverse effects. Similarly, for paralytics, they're not what we would consider first line. And it's usually more where we start to think of barbiturates and paralytics when we're dealing more with refractory intracranial pressure that's not responding to these early treatments. And there's some data for hypothermia, but really what is key is to prevent hyperthermia in these patients. So ensuring that they're normothermic is sort of the key in the treatment of ICP. And then there's definitive measures, which of course is craniectomies, craniotomies, and evacuation of the brain mass or hemorrhage. And we have case examples at the end to sort of demonstrate how we use this tiered approach in managing intracranial pressure. I do want to spend maybe just a couple of minutes talking about multimodal neuromonitoring, because this is gaining a lot of interest and traction in the field of neurocritical care. And multimodal monitoring encompasses the invasive monitoring that we such as ICP that we just talked about, as well as non-invasive such as EEG, and then both local or regional monitors such as the ICP monitors, and more global monitors again such as EEG monitors. And it also includes monitoring that can measure brain metabolism through microdialysis catheters, brain tissue oxygenation, and cerebral blood flow through transcranial Dopplers, which again are non-invasive. And there is a growing interest in using a multimodal approach, so combining these different modalities in patients with acute brain injuries in order to provide more targeted treatment. And the reason why there's growing interest for this is that we know in patients with acute brain injury, whether it is traumatic injury, whether it was an intracerebral hemorrhage, whether it's anoxic brain injury, independent of what the initial injury type was, there is a cascade of secondary brain injury, which is very complex and multifaceted, and it's mediated not only by the high ICP, but there can be cerebral ischemia, there can be excitotoxicity, seizures, oxidative stress. And so, the thought is that using just a single marker, ICP on its own, may not be capturing this very multifaceted nature of secondary brain injury. And so multimodal monitoring really allows us to capture this complex dynamic nature of secondary brain injury and provide more goal-directed treatment or goal-directed therapy. And I would liken it or compare it to, for example, using CVP in isolation for volume status. It doesn't suffice, and you have to have a more comprehensive picture to get a understanding of volume status, or goal-directed therapy for sepsis. So similarly, having a multimodal approach allows you to integrate all these different measures to provide a more complete management. And here's just an example of a patient that has not just an ICP monitor, but a brain tissue oxygenation monitor, microdialysis monitoring, as well as their MAP and cerebral perfusion pressure. And what you can see is that as the ICP goes up, there's a reduction in brain tissue oxygenation, there is an increased brain metabolism, and of course, a drop in the cerebral perfusion pressure. And so this shows you that, it's not just the ICP. So for ICP on its own, we would be giving mannitol in 23%, but for reductions in brain tissue oxygenation, other maneuvers could include increasing, transient increases in their FiO2, for instance, or if they are, if their hemoglobin is less than 7, even considering a transfusion. So there's other interventions that we could take. And we've certainly had cases where we see rises in intracranial pressure with no major change in brain tissue oxygenation or perfusion or metabolism. And so in these cases, we may want to be a little less aggressive in how we're treating the ICP. And then there are cases where there might be very subtle changes in ICP, but with profound changes in brain tissue oxygenation. And so there we'd want to target the brain tissue oxygenation more. And so that's sort of the reasoning behind using, or the increasing interest in using, multimodal monitoring. And this has also really been made possible now through new devices, where through a single bolt or single casing that have multiple lumens, we can actually have multiple monitors going in. So this is an example of a quad lumen bolt where you can put in a depth EEG electrode, Lycox or microdialysis catheters, blood flow monitors, as well as intracranial pressure monitoring. So all can go in within the same housing. And then we have monitors that can display all these findings, and sort of you can correlate all with each other. So there's been numerous advances and interest in using this sort of multimodal approach. And just to end with some data to support this. So this is the largest trial that looked at intracranial pressure monitoring in traumatic brain injury patients. And what they found was that while monitoring does result in lower ICP, it didn't equate to an improvement in outcomes. And so, the hypothesis was, is it just the ICP on its own? Are there other factors that we need to consider? And there's been a subsequent phase 2 trial called the BOOST trial. This was a feasibility study that combined intracranial pressure monitoring with ICP monitoring, and found that this is feasible to do, combine the two. And what they found was that when treatment was being targeted towards both ICP and brain tissue oxygenation, there was reduction not only in the ICP, but also an improvement in brain tissue oxygenation. But in those where the brain tissue oxygenation monitor was blinded and all you had was the ICP, while the ICP was controlled, the brain tissue oxygenation was in fact not optimally controlled, or was abnormal in those patients. And so it shows that it's both feasible and that it actually improves the brain tissue oxygenation. This was a phase 2 study, and so it wasn't powered to look at outcomes. However, there was a trend, non-significant, but a trend towards better outcomes in those that had combined brain tissue as well as ICP monitoring. And so right now ongoing is the BOOST 3 trial that is doing this at a larger scale, again, powered specifically for examining outcomes, and using a tiered approach that combines both ICP and brain tissue monitoring. And so hopefully in the next year or two, when I come back, there'll be more data regarding that. So switching gears now to talk quickly about disorders of consciousness. This is a very frequent finding in the critical care setting, where the patient is not waking up or they have impaired awareness. And so consciousness is comprised of both arousal as well as awareness. And it ranges from patients that are comatose, where both arousal and awareness is significantly impaired, to when they're in a vegetative state where they have impaired awareness and arousal, and then delirious stages where you have fluctuations in both awareness and arousal. And so, delirium versus coma. So the key feature of delirium or encephalopathy generally fluctuates. There's impairment in arousal and attention, whereas in coma, there's usually no fluctuation, and there's impaired awareness as well as wakefulness in these patients. And so the list or the etiology is exhaustive. I'm not going to go through this, but it ranges from infectious metabolic derangements to structural abnormalities. I think one of the key things to know is for patients that are comatose, a stroke or a unilateral lesion doesn't typically result in coma. It either has to be bilateral or it has to be a brainstem region that results in coma when it's a structural lesion, non-convulsive status epilepticus, and then of course endocrine abnormalities. So this, it's an extensive list. And the key really is, how do we work them up? And of course, that starts with a good history. Do they have a history, of any medication or drug exposures? On exam, assessing for movements, is there subtle movements suggestive of seizures? The pupillary exam, so different brain lesions in the brainstem at different levels have classic findings of what the pupils look like, and that can clue you into where the lesion may be. Eye deviation, a key thing to know is that, you can differentiate between stroke and seizures. In seizures, the eyes look away from the side of the seizure, and for strokes, the eyes look towards the side of the stroke. So if you're seeing gaze deviation, that's, forced gaze deviation, think seizure or stroke, it could be either one of the two. Then, of course, using, laboratory workup, toxic metabolic screens, LP, if there's concern for infectious etiologies, imaging, and then finally considering EEG monitoring in patients that have altered mental status. For imaging, CT is the fastest, especially if you're concerned for a hemorrhage or a bleed. MRI, looking for more subtle findings, and if there's concern for venous sinus thrombosis, ensuring you get MRVs or CTVs. But I'll spend some time talking about EEG monitoring because I think that's what we consider most often when when we don't have a good cause for altered mental status. So when to consider EEG monitoring in patients that are altered. And the most common indication, so this is published by the American Clinical Neurophysiology Society, in patients that are altered after clinical seizures, if they're persistently altered. In general, after clinical seizures, the patient should have improvement in their level of arousal and awareness within 30 to 60 minutes. And so if there's persistently abnormal mental status beyond that time point, consider EEG monitoring. Any brain injury with altered mental status that is out of proportion to what you would expect. So a stroke with deficits that match up to the stroke, I wouldn't consider EEG monitoring, but a small stroke that would normally just result in right arm weakness, for instance, but I'm also seeing fluctuating aphasia or fluctuating confusion, I would consider EEG monitoring. Unexplained altered mental status without CNS injury, patients that are at high risk for seizures, but need paralysis. So, for instance, ECMO patients, patients that require pharmacologic sedation, using EEG monitoring to guide sedation in those cases, particularly refractory ICP or status epilepticus patients, and those that have paroxysmal events that we're trying to rule out seizures. And then finally, for prognostication, particularly in anoxic brain injury patients, we often use EEG for prognostication. Seizures are not uncommon. They're actually seen fairly frequently in patients that are critically ill and comatose. And these are some of the most common etiologies for the CNS, trauma and hemorrhagic stroke and infections. And then sepsis-related encephalopathy. So there's a growing body of literature that patients with sepsis and sepsis-related encephalopathy also have a high risk for seizures. So consider monitoring those patients, especially if you can't find any other clear etiology for their altered mental status, or if they have a history of prior brain injury or prior structural abnormalities, to consider EEG monitoring. And there's evidence for patients with acute brain injuries, for anoxic brain injuries, for seizures and status epilepticus, as well as systemic illness in the absence of a brain injury, that increasing on the x-axis here is increasing burden of seizures and seizure-like activity on the EEG, and on the y-axis is the probability of poor outcomes as defined by modified Rankin scale. And across all etiologies, increased burden of seizures and seizure-like periodic and rhythmic patterns that we often see are associated with worse outcomes. And so that's why there's interest in monitoring. I will say that while we have evidence that seizures are frequent, that they're associated with worse outcomes, there's work ongoing now to sort of help us understand how best to treat them, because treatments themselves also have adverse effects. And so, the risk-benefit trade-off of management is a big area of research right now in the field of neurocritical care. Finally, very quickly, disorders of movement. We already talked about seizures, so I won't belabor this more, but they can be focal with or without impairment of consciousness, or you can have tonic, clonic activity. And when you're uncertain that an abnormal movement is seizure or not, we can do EEG to capture these. Disorders of movement also include decreased improvement from neuromuscular causes. The two most common neuromuscular emergencies we see are myasthenia gravis and Guillain-Barré or acute inflammatory demyelinating neuropathy. How to distinguish between the two? Myasthenia is typically a motor disorder with fatigable weakness and intact reflexes. Guillain-Barré typically has a combination of both motor and sensory changes, ascending weakness and loss, and they often have profound autonomic instability. I think the key takeaway that I have for these neuromuscular disorders is that we shouldn't be relying on their ABG because it's not a reliable marker of their respiratory status. And their ABG actually becomes abnormal at a much later stage. And so for these patients, monitoring their vital capacity, maximal inspiratory pressure, and using pulmonary mechanics is sort of the key, and to consider intubation when we start to see decompensation in the pulmonary mechanics, even if their ABGs are not yet reflecting that change, as that's sort of the key for patients with neuromuscular disorders. Other disorders of movement include critical illness, neuropathy, and myopathy. Typically, these are recognized when patients have generalized weakness and difficulty weaning off ventilator. EMG and nerve conduction studies can help distinguish between the two. A key feature is critical illness neuropathy may also have sensory symptoms. Typically, CK is normal. Myopathy is only motor. They may have CK elevations and no sensory findings. And then prognosis really depends on younger patients tend to do better. Older patients, those have received prolonged courses of steroids or prolonged or much higher illness severity, those are the ones that tend to have worse prognosis. But in general, many of these patients, especially if we discontinue steroids early or discontinue neuromuscular blockade early and anesthetics and sedatives early, can go on to have a reasonable prognosis. And then, so just in the last few minutes, I have two case studies. One is of a 50-year-old male admitted after an MI, has a PCA, and post-angio is found to have left-sided weakness, and images show a stroke. And over the next 24 hours, the patient becomes increasingly somnolent. And so you can see here, there's a CT scan. We see a right MCA distribution stroke over here with some mass effect. And this is the subsequent scan that now shows some hemorrhagic transformation and increasing mass effect, where you see some midline shift. You can see the entire ventricle here on this side, but here you can see that even the ventricle on the left side is now getting compressed. And so there's clear evolution of edema. And so then again, going through how to approach these patients, the goal is lowering ICP and preventing further tissue shift. So we want to prevent this patient from actually herniating. We'll ensure they're euthermic, euglycemic. For this patient, if seeing that scan and seeing that they're more somnolent, if they have peripheral access, I would immediately administer a dose of mannitol. At this stage, I wouldn't consider ventricular drainage, barbiturates, or hypothermia. Those are sort of for refractory cases. You could consider hyperventilation, but here where there's clear mass effect and risk for herniation is when we want to think about, could this patient be eligible for a decompressive craniectomy? And so for patients with ischemic stroke, there were 3 trials that looked at patients less than 60 years old, and they found that early decompressive hemicraniectomy for large malignant strokes within 48 hours were associated with, not just survival, but better functional outcomes. There was a subsequent trial that looked at older adults, which again found decompression was associated with survival, but not necessarily with improvement in disability. And so, you have to keep the big picture in mind. And so for this patient, if they're younger, especially younger than 60 years old, if it's a large stroke, we see there's evolving edema, and we use sort of their clinical exam if they're starting to get more somnolent. It's a large stroke. Outside of the stroke, they have no other major comorbidities. We do consider urgent or early decompression in these patients. For older adults, it's a risk-benefit trade-off. It can, it can result in survival, but not necessarily improve disability. And so it's a conversation that we often have with families. But typically when we're considering decompression, it's for younger, younger adults less than 60 years, or, now even we're extending that to even less than 70 years, especially if they have a good premorbid state, that you can consider a decompression in these patients. Decompressive surgery for other types of injuries. So for intracerebral hemorrhage, in general, trials have shown, decompressive surgery can it can improve survival, but not outcomes. So again, we will consider it as a life-saving measure, especially for younger adults. In patients with traumatic brain injury, similarly, craniectomy has shown to improve survival, but not a level of disability. And so we will, it's often considered in, as a life-saving measure, especially for younger adults presenting with severe TBI that have impending herniation. And very quickly, I'm running out of time. We have a 65-year-old who was admitted for pneumonia, and after weaning sedation was found to be unresponsive with intermittent twitching. And so, extensive workup is done, but this is a patient where I would consider EEG monitoring, and they were found to have non-convulsive seizures. And so just an example of when to consider EEG monitoring, and a quick overview of treatment of status epilepticus for these patients, where first line is typically benzodiazepines, second line is phosphonatoin, valproic acid, and levetiracetam. Again, data shows they're all equally effective, and so we just use comorbidities to guide treatment and dosing. The main thing that I would like to have folks take away from here is that dosing is key. Patients with status are frequently underdosed both benzodiazepines as well as second line agents. So just ensuring that they're being dosed appropriately is the key. And that is all I have. Thank you for your attention. And I know we have a Q&A section later, so I'll be back for that.